and we'll probably turn some time over to Chief Cook during that time. And anyway, get on with it. So I am kind of a history buff a little bit when it comes to antiquities and medicine and things like that. So I wanted to just bring up this idea of intubation and how it started. So we have record of this happening clear back as early as 3600 BC. Back when they did it in the early days, they were doing, based on this picture, a vertical incision, and this one actually looks like maybe they went between the cartilaginous rings, but some comments from some of the early physicians made it sound like they were primarily doing a vertical incision, because some of their concern was for carotid artery laceration, infection, but also that the lips of the wound wouldn't heal together because they were both cartilaginous and not of a nature to unite. So kind of interesting that this is how they were doing early intubation, if you will. So this handsome guy, Andreas Versalius, in the 1500s, used a reed of grass and put it into the trachea of a dying animal and realized that if he blew into it, he could sustain life. And so that became a way for future people to kind of build on. And of course, as we see new diseases and that sort of thing, we have to become more inventive with our therapies and treatments. And so this next guy ended up doing a tracheotomy on a paratonsillar abscess. And then later, tracheostomies were performed for multiple problems, including diphtheria. And diphtheria has necessitated a lot of different airways. We'll kind of look at diphtheria. Luckily, we don't have this very much anymore. They include diphtheria in your Tdap, the tetanus, and with acellular pertussis. So we're vaccinating for this. But with diphtheria, you form this, it's called a pseudomembrane, this thick, nasty, white debris. It's kind of built up of keratin and white blood cells, and it kind of thickens up, and then people can't breathe through it. So this gentleman came up with a series of metal tubes where they could actually put those in a tracheotomy fashion to bypass that upper airway obstruction. This is called a bull neck. Luckily, we don't see this. So that was kind of the way that we were doing some of the early ventilation, but we didn't really use anything to look down the airway. Any intubations that were being done were done with indirect visualization. So this is kind of an interesting picture. I've shared with everybody that when I was in medical school, I did a ear, nose, and throat rotation, and the guy that I worked with was kind of old school. So he literally wore one of those headbands that has the mirror on it, and he made me do this. And it was so hard. So this is a light source in the middle, and of course he's got the mirror on his head, and then he's got what looks like a dental mirror, and he's kind of shining and beaming the light from the light source to his mirror to the mirror in the mouth to be able to see into the airway. So hard. Anyway, grateful we don't have to do that anymore. And then they started modifying scopes that they were using for other purposes to actually look more directly into the airway. This one looks a little barbaric. You can see, like, this is the guy's chin. This is kind of a crappy picture, so I apologize. But you can see how far back his head is hyperextended. And then there's this bar that's kind of stabilizing this whole apparatus, like, on his chest. Another thing that I came across that they used to do is something called suspension laryngoscopy, and essentially it was like an IV pole. You can picture that hanging over the patient, and it had like this huge contraption like this that was suspended above the patient to access their larynx and visualize, which is crazy. Yeah.
I'm gonna still it just for.
Okay. I'm glad you know what you're doing. Let's see if my clicker works. Hey, it works. Okay. All right, so surgeons caught on to the benefits of giving gases through the airways that they were developing. And then from there on, surgery and anesthesia kind of took over the airway. They've just kind of run with that and have been the managers of the airway, although we are there with them now. So over time, they developed different products, calling it the otoscope from an early age. And today, we're still seeing a lot of innovation. So I know you guys carry the Glide Scope. This is a new one that's supposed to be all the rage that is a Medtronic. It's called the McGrath, I think, through Medtronic. And then this is my new favorite, the hyperangulated blade. And I didn't ask it today. Do you guys have these?
That's the only one we have.
It is,
We
okay.
started with that one from the beginning.
I love it.
We have
So-
avoided going to the standard geometry.
And I think that's great. Yeah, I don't even use these anymore. I mean, because I don't want to have to trade out my blade if someone does have a really anterior airway. So I feel like this has been really helpful. So I love that you have that. So a little bit about ventilation. So William Hawes, an early physician, started paying people to bring in patients who had drowned. And of course, they had to have been drowned pretty recently because his goal was to resuscitate them. And was, paying people money. So glad we don't live in that time either. So some initial ways that they were ventilating people, they would use wooden pipes through the nose and blow in through the nose through these wooden pipes. They used the bellows in a myriad of ways, including in through the mouth, but also, interestingly, they used it with a flexible tube for blowing tobacco smoke through the anus to revive vestigial life in the victim's intestines. Of course, this was later discontinued when physicians figured out that the body just didn't really work that way. But there you go. So thus the saying, right? Anyway, I digress. Okay, so like I said, I mean, hopefully this is gonna feel like it applies to all of you. There's a lot that needs to be done. We'll go through cumbersome checklists on things that need to be done, so look for what role you could play. All right, so you guys are the stat intubators. Everyone's gonna look at you on scene to do something. So to intubate or not to intubate. So this is something that I kind of learned when I was in medical school that I have kept doing. So when I get a cardiac arrest, I actually don't intubate right away. I know they've done a lot of research even on passive oxygenation and things like that. During cardiac arrest, they did some research down in Salt Lake that I helped type up and stuff a long time ago. But we know that bagging can be really effective. So I don't typically intubate until we get ROSC. So I don't know what your techniques are, but we've shown that when we do try to intubate, we're spending more time off the chest and then we're having to build up that perfusion pressure again. And so you're sacrificing a lot to be off of the chest. So there is some information out there. So this is the National Association of EMS Physicians. And they did a literature review to look back and see, what was the data on BVM versus supraglottic airway or versus endotracheal tube intubation, and then supraglottic versus ET tubes. And they didn't really come out endorsing one particular thing over another. Because if you're doing good bagging, if you've got a good king airway, if you've got, whatever it is, we're ventilating our patients well. They're all pretty equivalent. So it really has to do with what your level of skill is and what your protocols are. This other one that I found does talk about there's probably some benefit in a traumatic arrest, especially if it's from chest trauma, or if your transport time is going to be longer than about 15 minutes. They did recommend to intubate for a traumatic arrest. And then this one's in hospital, and this is probably more closely aligns with what I do, so it just kind of talks about they didn't see any improved mortality outcomes or any benefit long-term if you were intubating before about the 15-minute mark with a cardiac arrest. So it doesn't really mention ROSC, but under 15 minutes they say it's probably okay to bag and not intubate. So I'll defer to whatever you guys choose to do, but that's what I do. So our goal today, become a great airway manager. And most of this lecture is going to be based on some ideals that were put out by Scott Weingart. So he's kind of the guru in emergency medicine for airway. So he's a classically trained emergency room physician who went back and did some fellowships in trauma and critical care and has pumped out a ton of research and information about airway stuff. So first we're going to talk about technical skills, how to use the equipment, and then knowledge of sequencing, and then later we're going to get to peri-intubation complications and the physiology of that. If you guys have questions or thoughts, just stop me, okay? Okay, so this is from your Utah EMS protocol, which all of Davis County has adopted. Of course, you have your variants for your RSI protocol, and we're gonna include that here in a little bit too. But important to get a focus history and physical exam, you know, what led up to this problem. So for me, just as an example, if I found out from a history that someone was having a choking episode before their cardiac arrest, I would look at that airway. So that would make a difference for me to know that that airway might be compromised, they might have an airway obstruction, and I needed to get in there and look. So. Good. So looking for reversible causes, you know, so someone has, you know, a respiratory arrest. Is there something that you can do about it? Maybe their airway's compromised just because they're hypoglycemic. So considering some of these easy reversible causes ahead of time is important. All right. This was a lesson I learned on my paramedic ride-alongs. We were treating a stroke patient, and my preceptor was like, kind of slapped me on the wrist a little bit and was like, you got to do BLS before ALS. And I was like, okay. So it is so important. So you can't do good ALS without good BLS. So just remember, that's important. The state protocol talks about BVMs preferred for patients under 10, and your RSI protocol says patients under 12. So keep that in mind. There's always going to be some exceptions to that, where you're, you know, they are guidelines. So, and then CPAP, BiPAP, and then high flow. We talked a little bit about high flow yesterday. I love that you guys have high flow. And we kind of talked about, and tell me if you've used it outside of a transport, but typically it's being used inter-facility. Is that what you would say? So I don't know how many kids you feel like you're picking up from like urgent cares and clinics like that. I mean, it's group season right now because we're in the spring. But they are like the perfect kid that needs this. Those kids that like you find they're breathing super hard, maybe they're actually oxygenating okay, but they're working super hard. That's my favorite person to put on a high flow nasal cannula. Maybe it's that BiPAP patient that's an adult that just isn't tolerating the mask. Kind of another consideration. All right, so deciding to take an airway is a big deal. We have a hard time mimicking sometimes the body's natural mechanisms for homeostasis. So COPD and asthma are traditionally really hard to have to really think about if you're going to intubate those people. Also, I would argue anyone that's in a really acidotic state, so like DKA, just because their respirations are fast for a reason. So if you are intubating some of these people, look at what their physiology is ahead of time, and sometimes you need to mimic that so that you can blow off acid or whatever you need to do, the CO2, to get them where they need to be. And it's a big deal because we're trying not to get to that point. Yes?
Sorry, I was trying to catch you before you switch.
Oh, you're good.
Does anybody know who that actually is on the board?
Hilarious.
Oh, I'm surprised.
MacGyver.
I'm shocked.
Now you're making us feel old. Come on, man.
It happens to me like 20 times a day around.
Yeah, no, I feel you. All right, so indications for intubation. So we always say, you know, GCS less than 8, intubate. I think that's an easy rule, and I like it because it's so easy to remember. We all know about this idea of gag reflex, and I think a lot of people, and I used to do this all the time too, put in an OPA just to see if they'll take it. But there actually is a way to tell if the airway is compromised that is more specific or sensitive than a gag. Does anybody know what that is? So it's pooling secretions. So if they have gurgling spit in the back of their airway, that's actually more telling that they need their airway protected than if they have a gag or not. So typically what this looks like for me is I will grab a tongue depressor and my light, and I look in the back of their throat. Well, while I'm doing that with that tongue depressor, I'm kind of jamming it far back there also to assess for a gag, but ultimately I'm looking to see if they've got gurgling spit in the back of their throat. So, let's see. So I wanted to hit on iatrogenic causes. So recently I had, iatrogenic just means something that maybe we would have caused, you know, some of our treatments may have caused. And so if you think about this, I had a young, small framed woman brought into me the other day who had a seizure. And she got 10 of IM Versed. Well, the crew probably didn't know, I didn't even smell it on her, but she was pretty liquored up. And so by the time you hit her with 10 of Versed on top of the alcohol, she was gurgling in the back of her throat. And I kind of tried to decide for a little bit, hopeful, keeping my fingers crossed that she would just start swallowing and maintain her own airway a little bit better, and it didn't happen, so I ended up intubating her. And she wasn't intubated for long, but she also didn't aspirate, and I'm glad about that, but they ended up extubating her in the ICU later in the day. But I think she needed that airway protection during that time. But just remember, some of our treatments can cause this, so, you know, I wasn't gonna give her a reversal agent for her Versed. The best thing to do is intubate her. And then safety during transport. I mean, sometimes we do this ahead of time when we know you're gonna come and pick someone up for us. But think about maybe like a ketamine administration under the same circumstance. Like sometimes, again, we don't know what sort of intoxicants the patient already has on board. And so now you're giving a big slug of ketamine for their excited delirium, and now they're like tanking, you know? Sometimes that happens. All right, so RSI. So we know that we're doing RSI really in someone who we need an urgent airway. We're using an induction agent and a neuromuscular blocker. We do it because we need rapid airway control if someone's going downhill really fast. We want to minimize that apnea period. They're maybe vomiting, or we're worried that they're going to vomit. Certain populations, like pregnant women, are going to be more at risk for aspiration and vomiting just due to the nature of their anatomy. Or if they have distorted anatomy, and this one is kind of a double-edged sword because I'd say it might be a reason not to do rapid sequence intubation too, so you have to consider that. But is it airway edema? You're trying to get that tube in because it's a burn, and you know that right now you have access to an airway, but in 10 minutes you won't when everything starts swelling. Or maybe trismus, you know, if someone's really clamped down and you just can't get in, then you're gonna have to give some meds. So why not? So again, I mean, maybe they're in cardiac arrest, and in those patients, you shouldn't, in theory, need to provide any sedation because they're dead or paralytic. So children under 12, like I said, per your protocol. Refractory hypoxia. So we're going to talk about that in a little bit, but essentially means, you know, you're trying to pre-oxygenate with no good success. And then the 4 Ds of a difficult anatomy, or difficult airway. So considering, you know, is this going to be a difficult airway? Do I really want to paralyze somebody and then risk that can't intubate, can't ventilate situation? All right. Everybody's got a checklist. So I want to know, what do you see in this picture that looks good? What do you like about what this guy's setup looks like?
Elevated.
Okay, head's elevated, position, good.
Pre-oxygenating.
Okay, good. And I am going to point out on this pre-oxygenation, because we're going to talk about it, and I haven't pointed this out with the other classes. But I see a green thing from the non-rebreather, and then what do you think that is? A nasal cannula, and we're going to talk about that in a little bit. And maybe it's end-tidal CO2 with your nasal cannula, which can be helpful. So that if you do get that tube and you're using some, I don't know, you can't really use the nasal cannula. Do you guys have a different thing that's in line for your ET tubes for end-tidal? Okay, so you'd have to maybe switch that out. Okay, what else?
Fluid resuscitating.
Say it again.
Fluid resuscitating.
Fluids, perfect. And that's through 2 large bore IVs that look like butterflies from here, but whatever. What else?
Pads on.
Pads on, okay. Lots of monitors are there, right? So, good. Okay, somebody the other day said he's already got the 2-block device behind the neck, so you're not fumbling through that.
Suction also.
Oh yes, thank you, suction, thank you. Very, very important, suction. All right, so the 9 Ps of intubation. So a plan, which hopefully everyone's got in their mind ahead of time, you know, what this all looks like, right? That's why we're here today, we're planning. Preparation, this starts at the beginning of your shift, and I've told on myself with every lecture, so I'm just gonna tell myself again. We got called to a nursing home when I was working on the ambulance, and shift change had just happened. We get in there, it was like a trivial, like 32 Bravo, like nothing major. When we got in there, the patient was not breathing well. It turned into this nasty respiratory thing. And as soon as we looked to the head of the stretcher to hook him up to oxygen, of course, guess what was missing? Our tank. And so the crew before us didn't put the tank back on the head of the stretcher. I don't even remember where they left it. So we got him out to the ambulance as quick as we could and got him on our wall oxygen, but we looked like total morons when we rolled into the hospital and the patient wasn't even on oxygen. So make sure you're doing your checks at the beginning of the shift. Let's see. All right. So I thought some of these stats were interesting. 10% of patients trauma patients with a GCS less than 9 are going to have a cervical spine injury. So high suspicion, that's actually a fair amount. Most of the movement that happens with intubation is actually during bagging. And so one idea is to remove the C-collar and actually have one of your partners hold manual stabilization. So the C-collar is not going to provide you feedback, you know, hey, you're moving all over the place, but your partner definitely can be like, hey, we're moving a lot, you know, we got to have less motion or whatever. So I think that's important. All right, so this is your checklist on your RSI protocol. So a lot of this, again, is taking place at the beginning of your shift, just making sure that you're checking out your equipment ahead of time, making sure your laryngoscope has battery and light that are working. Let's see, suction. Somebody said that your suctions just got revamped. Portable suction is always a nightmare, but hopefully those are working if you have to do that. And it sounds like most of the time you're intubating in the back of the ambulance anyway, so you'll at least have your wall suction. And then patient position, this is an important one for me. We all want to have longevity in our field. You guys have a hard job because you're lifting and moving people nonstop. So where you can, protect your back. This is about visualization and optimizing your view, but it's also about saving your back. So you just don't know how long you're going to be there trying to get access. And so if you are there for any length of time, you want it to be comfortable for you so that that's not a factor in your success ultimately. So, okay. So this is your pre-oxygenation strategy, and I'm kind of going to go over it really briefly just because we're going to hit some other ideas here. But generally with the pre-oxygenation, it sounds like SATs have to be above 90%. And if SATs drop below 90%, that's what's going to prompt you to come out and bag the patient up again. So just remember, you know, we talked about the other day, holding your breath. That never, I mean, has anyone ever done that? Holding your breath while you suction or try to intubate? Like, I've never done
They
that.
actually
Like,
taught our group back in the day that
That's
our
what I'm saying.
intubation attempt needed to be when we held our breath. And if we couldn't breathe, that meant the patient couldn't breathe and we needed to stop our
yeah, but how are you breathing when you're putting in a tough tube?
Precisely.
I'm
Elevate
breathing
your
fast
heart
as
rate.
hell. Like,
Yeah,
not,
yeah.
not holding my
It's the
breath.
most ridiculous
My brain
bullshit.
needs all the oxygen it can get. I'm doing high level stuff. So yeah, it doesn't make any sense. So anyway, no one's gonna sit there with a stopwatch, although some places recommend that. So just SATs above 90. Okay, so pre-oxygenation. So we're looking to extend the safe apnea time to the extent that we can. And we know that it's gonna be lower in patients who are obese, critical illness, especially these COPDers and stuff that don't have any reserve anyway, airway occlusion, increased oxygen consumption or anemia. I always intubate with a cannula in place. I've gotten some funny looks from respiratory therapists who are like, I have a BVM right here. I'm like, yep, and I want a nasal cannula on. So the trick with this is you do have to have the 2 ports, but I've been told you have 2 oxygen ports in the ambulance. So one goes to the BVM and one goes to the nasal cannula. So that's going to help with nitrogen.
Therapy hasn't been read into the notion of apneic oxygenation.
What hasn't? Sorry.
Therapy, respiratory therapy.
No, they really haven't.
And it's across the board.
Even
It's
the
not
new
just-
ones, even the young
Yeah.
ones. And in fact, I would say the guys that have been around for a while have probably brushed up on some of the new literature. I don't know, but the younger ones are the worst
Oh,
because they think they know the most.
say that again.
Anyway, they don't know what they don't know. But part of this nasal cannula is the nitrogen washout, so we're trying to maximize their, all of the oxygen that's within their lungs and push that nitrogen out. And then, let's see, a non-rebreather also. So, I can't remember if this is from I don't think this one is from your protocol. I think this one's from something else, but anyway, we're gonna talk about that. Nobody's doing pre-medication. Don't stress about pre-medication. The fentanyl, I never saw that in pre-medication. When I was working as a medic, it was more just atropine, but anyway, no one's doing that. Okay, so paralyzed with sedation, but usually it's gonna be the reverse. So you guys carry etomidate and ketamine. Who's using what? I'm curious, because I've told people are using etomidate, but I have yet, I feel like, to meet anyone that actually is using etomidate. Are you
I didn't
all
say a
using
word.
ketamine?
I did not say a word. You told on yourself.
Did you just say that you're using etomidate?
Jason likes to tease me for exclusively using it.
Hey, I use etomidate. I don't use
See?
sucks.
Wisdom, right?
But I use etomidate, but because it's a logistical thing for me. So for me, ketamine lives in the Pyxis and not in my RSI kit, which is kind of a pain. And so for me, it's etomidate and rock. But what are you using? No one wants to say. Ketamine and rock. Did anyone say etomidate? I didn't hear it. No. Is anyone using sucks?
Just,
No. Okay.
the accommodate sucks, I'll fall on the sword.
All
Works
right.
every time.
Way to stand tall.
60%.
Okay, let's see.
Just like being a contrarian.
A little bit.
So there really isn't an ideal RSI agent. It really, I think, a lot of times for most people comes down to what you're comfortable with. I would say there might be a certain time when you're like, oh, maybe I shouldn't use this. A lot of the contraindications are kind of theoretical, and we're going to talk about that in a second, and things that we don't really have to worry about. I think it's really about what you're comfortable with. All right. So neuromuscular blocker, it's going to allow for higher intubation success, less airway trauma for sure, and hopefully let us use lower doses of sedation, which we know can cause hypotension. So tell us about your sucks use. I mean, are you waiting? Are you watching for fasciculations before you go in? Yeah. And one of the newly graduated paramedics said in the OR they're actually using, I'm not advocating for this, but if you're doing sucks, they said they also give a little whiff of Versed to kind of offset the fasciculations, which I thought was interesting, but it's just another thing. Yeah, but in your world too, I mean, it's another thing to draw up. It's just one more thing. Like you already have so many things. So anyway, so that is one disadvantage is you have to kind of wait for that. Although the onset of sucks is a little bit faster than rock, even with that two-phase approach. Man, you know, I thought about it. What's better for calls? 8, noon? We didn't do 5.
It's just that you're training.
I know, it's
that's
okay.
causing it.
We're not missing much. So there are a couple advantages to sucks, I would say. It is a little bit quicker onset, so you can see rock has a 60-second onset, where with succinylcholine you might have 15 seconds, give or take, that your paraleg's kicking in quicker. And then also the duration. So if you're anticipating a difficult airway, sucks is not going to last as long. So you're going to be left bagging or trying to decide about a cric for only 10 minutes potentially, when compared with 20 to 35 minutes on the duration that rock's going to last. Rock does have a reversal agent. I've never used it. I've never seen it. It exists. It's probably in the hospital somewhere in the pharmacy. You guys don't have it. So rock is good if you know that you're going to have a long transport. It sounds like you guys are all using this anyway, which is good. All right. So this is kind of one of the other topics that we were going to talk about today that I'll turn the time over to Jason. But just generally, we don't want anyone to have awareness in their paralyzed state. So they have a lot of case reports where people have had PTSD results. This is also kind of a high risk from like a litigation standpoint to have someone who actually has awareness. And you can imagine how scary that would be. They've interviewed people where they felt scared that they were going to be paralyzed forever. But you can imagine someone coming at you with this laryngoscope blade, in your mouth. Remember that, the medicines that we're giving for paralysis do not prevent pain either. So if you're giving only this, you're not treating their pain. They're feeling all of the discomfort of everything that you're doing to them. So it's a pretty scary situation. So I'll turn it over to Chief Cook.
The department had a couple recent events. It was ironic the way that this timed out, but we've had a couple recent events where for occasions that the crew was on scene, they felt like the most appropriate thing to do was a paralytic only intubation. One of them was the electrocution that your crew went on. So because that fell outside of kind of what our established guideline is, Chief Mon asked that we refer those through Dr. O just to get some feedback on them. Because there was some intelligent, good decision-making that supported it in the moment, but retrospectively, like, what should we be doing going forward? So Dr. O looked at both of those, talked to a few of his peers over a period of days, looked at our protocol, and kind of settled on this. I don't mean kind of settled on this. When we do an RSI, essentially always, we should be using a sedation dose of some sort, which might be the negotiable part. Not that we're going to use it, but what the dosing may look like. But we will be using sedation along with the paralytic every time. So let me go back on what some of the fear is. So one of the things that got expressed to me from one of the crews was, this guy was big sick, he was big hurt, and I was super, super afraid of what was going to happen with this hypotension once we push the meds. And Dr. O and I and others appreciate that. That's an understandable thing. In fact, we're going to talk more about that. But Dr. O's comment was that's all of who we RSI, are people that are super sick and super buggered up, right? And over thousands, hundreds of thousands or more intubations, both cocktails of RSI meds have proven to be safe. And so the fear of inducing more hypotension that we can manage otherwise, and we'll talk about that here in a bit, is in and of itself not enough to not use sedation. That there are means and ways that we can add to the patient's care that's going to offset what we may do with the medications. So we will be using a sedation drug. The other thing too is he believes that we're in healthcare, not just Layton City, Jeremy and I talked this morning, we even see it at the other place, that we're over dramatizing the incidence of or the likelihood of that happening. And so we're kind of talking ourselves into, well, it might happen, so I'm not going to, or I'm going to use a lesser dose. And we're kind of walking ourselves back from it with an understandable but maybe an irrational fear of hypotension. And then the other reason is to standardize it so that there's not a debate, there's not dialogue, there's not misinterpretation between providers on a scene. We all know when we embark on using meds to assist in an airway that we're going to use a sedation drug paired with a paralytic drug to facilitate our intubation. Now that might mean we're going to do other things too that we'll talk about, but that we are going to use a sedation drug. Now we might lower that dose, all right? Jeremy recently had a flight where the doctor said, let's just give it, what was it? A piss in the wind dose, all right? Which in the end, it might just mean that it made all of us feel better, or it might mean that we can document that we did some dose of a sedation drug. But the message was crystal clear, which is why I'm here today to share that from Dr. O, that when we are purposefully using as part of our plan medications to assist in our airway management plan, we will use a sedation drug of your choice. and the paralytic, all right? So do me a favor. I'm gonna send an email out probably this afternoon or tomorrow to the whole department. But today, for your friends that are gone, your partners that are gone, please share from Dr. O, after looking at both of those incidents, that in all instances that we use meds to facilitate our airway management plan, we're gonna use sedation and a paralytic. Fair enough? The evidence is pretty clear, and he provided all the evidence, and I'll provide that to you guys. But the studies are very clear that sedation only and or paralytic only medication or airway managements have a lower success rate and higher complication rate than those that are paired with sedation and paralytic every time. So, you know, there are some, I've run into it, I'm sure Jeremy has, docs that are afraid of the paralytic, and so they want to do just sedation only. That's a loser, like that's a dead end, that's not helpful. And there's always gonna be a tiny little nuance, right? But in general, we're always gonna pair a sedation drug of some dose with our paralytic. Fair enough? Good.
And this is a little fortuitous, I agree. I think just that this coincides because I think the goal is to provide you with some ideas of how you can have success despite your concern. And I think we all come at medicine with our own experiences and our own, you know, PTSD, if you will, from previous cases that maybe went south where, you know, this happened and then this happened. I mean, I know I have that. You know, I could share a handful of them with you where it's like, man, shoulda, woulda, coulda, right? And how am I gonna do it next time? So hopefully we're gonna provide some good ideas of how to do it.
And I'm gonna add one thing. There is a lot of social media, I partake in it too, right? Like, I'm a fan of OneGuard. There's a lot of very interesting theory about how to provide care. And medicine is changing very rapidly, would you say? Much
Oh, yeah.
more so than it did probably even when you went to school.
Mhm.
Dr. O made it clear to me that, like, look, he's never gonna be the earliest adopter. He's never gonna be the front of the bell curve. But he's never, ever gonna be the end of the bell curve, ever. We, in fairness, we sit at the upslope. Like, we're never gonna be the first adopters, but we're right on the first of the uptick on almost everything. So you might see at the other hospitals or the, you know, summer shop or wherever, that a doc may do it differently than what we do. And you might be, well, like, so-and-so did it this way, like, we're doing it wrong. Understand that, like she just said, experience, circumstances, nuances, or whatever may change an approach. But we work for Dr. O, he's a very intelligent guy, he looks at the literature, and he's made clear what his expectations of all of us are. Fair enough? Okay.
All right, oh, just a really quick plug before we move on. Versed causes amnesia. Don't know if you know this. This is where I say, plug your ears. No, but, you know, if you only give a piss in the wind of sedation and your, whatever they said.
That was it. That was a good one.
You know, if you're only giving that much, but you're worried that maybe they did have some awareness as they were paralyzed, Versed is helpful. Versed also will drop your blood pressure, so you have to be careful, but maybe you get them to a more stable point, and as they're coming out of their, you know, rock paralyzation, you give them some, because that's part of your protocol to give Versed for sedation after the paralytic wears off. You're going to need some continuous sedation, right? Versed might be the choice. Okay, so this is our hierarchy of needs when it comes to emergency intubation. I mean, ultimately, the whole premise is someone has to survive this whole ordeal, right? Ultimately, the pinnacle is that they aren't going to have any awareness, and that is our ultimate goal. But if someone is alive, then we at least have achieved the foundational goal. All right. So protection. We don't really do protection. So this idea, some of you may have learned, maybe some of you don't know what I'm talking about when we say protection. So cricoid pressure, which is really called the Selleck's maneuver, is a maneuver that is supposed to be performed during intubation to try to prevent aspiration, not to align the airway. So we're not doing protection because no one's doing it for that purpose. And in all reality, when it comes to realigning the airway, we're doing burp. So does anyone know burp? Has anyone learned burp? Some people, Jeremy has, you guys haven't. I just found out from a couple of your recent grads, they're not really teaching this, so I will reach out. So burp is backward, upward, rightward pressure. So this is kind of hard if you're the intubator. It says you can do a two-handed approach where you've got your laryngoscope blade in there and you're manipulating the airway yourself. If I'm going to manipulate something, it's typically a head, and I'm trying to align my airway that way because I can reach that better than this. But if someone asks you for cricoid pressure, because that's what we all remember in our brain, give them burp. And remember that rightward pressure is the patient's right side, not your right, okay? So that's important. Okay, so positioning, super important. Like I said, I mean, sometimes you can put someone in a traditional position where you think that in theory the airway should be aligned, but they're really anterior, or for whatever reason you just can't see into their airway the way you need to. And so I like to manipulate the head by just picking it up, and probably some of you do the same thing or have seen that done. But I will tell you, sometimes we can kind of get locked into things. So a case that I had a really sick child who in theory should have been easily intubated in this lovely, slightly extended kind of sniffing position, right? This was like a special needs kid, and I had no idea why this kid was so hypoxic. It turns out later we found out that he had pulmonary hypertension, like super bad. And so there probably was no way I was ever going to get his oxygen good. He needed some pulmonary vasodilators and stuff like that. But I just clung to this picture. I was thinking I couldn't get in. I couldn't see his airway well at all. And I was like, well, he's a kid. This is the right position. Like, I shouldn't need to do anything else. Like, why can't I see? Anyway, Lifeline came in so they could transport the patient. And I still didn't have a tube. We were oxygenating the best that we could. And even when we got the tube again, his oxygen was crappy. But as soon as that Lifeline medic got in there to intubate, the first thing they did was pick up this kid's head and start manipulating it around. And I thought, well, why didn't I do that? And it's because I was locked into this picture thinking, no, I shouldn't have to do that on the kid. I just was locked in. And so don't do that. Just remember, you've got to be flexible and open. And at that point, I hadn't had a lot of experience intubating kids. This was pretty new out of residency, and so it was kind of helpful to have that humbling experience. And I guess the moral too is don't have an ego when it comes to intubating somebody. You know, it's just like an IV. If you try twice, you give it up to somebody else, and that's totally okay. We all have off days with everything that we do. So I was glad they got the tube. So this is a ton of work. This is going to take an army to find that many towels. You don't have that many in your ambulance, guaranteed. I don't have that many even in my ER rooms. But remember, if you've got someone who's obese, lifting the head of the stretcher is going to offload some of the work of the towels. And just remember, you need to align their ear with their sternal notch, and then their head needs to be facing the ceiling to really get good airway alignment. All right. Yeah, I'm sorry about the formatting. I changed all this and it went back for some reason. It looks weird. So keep using your Broslow tapes. I feel like these are super helpful. Pregnancy, you have to anticipate some of these problems, but since I just brought up Versed is great in a lot of ways, but Versed is also a teratogen. So just keep that in mind if you have a pregnant patient, especially when they're early, because they're going through organogenesis with their baby. This is going to cause birth defects potentially, so don't give that. Okay. So I like this because it shows the timeline of intubation. It's only 12 minutes. So if you think about those checklists that we put up, it's pretty cumbersome. There's a lot to get done. So remember, everybody has a role. I also like on this that it talks about the point of no return. So once you decide to give your induction and your paralytic, I mean, you're committed.
This seems so dramatic.
It kind of does. But it helps you feel that a little bit, right? I mean, I like that. So. And we should be thinking about our sedation and analgesia, even though, you know that your rock is going to last 35 minutes. Your sedation probably isn't. So we're trying to avoid that paralyzed awake situation. So make sure you're thinking about that after too. So, sounds like you guys are only using the video laryngoscope, the glide scope, which is great. We know from tons of studies that our first pass success is increased with video laryngoscopy, so that's huge. And this one talks about, this is from your protocol, one slide said 90, this one talks about SATs above 93 or heart rate of 60, then you're backing back out and stopping. So I don't know if the other slide was maybe from just the generic state protocol. Sorry about that, there's a little discrepancy. All right, so I want to know personally, what is your backup plan? I got like, this side you're all green patches, this side are all red patches. iGel, that's your backup? I like it. How about you guys? Have you guys used a bougie
Yes.
in real life?
Yeah.
Do you practice with a bougie?
Yes.
Okay, so that's important. So, you know, the saying is practice makes perfect, but I'd argue it's not that. It's perfect practice makes perfect, right? So if you're going to use the bougie in the field, you need to be practicing with it on a head. And I like the bougie because you can preload your ET tube. Hopefully it's rigid enough that once you get the ET tube at the cords, you can actually use it like a stylet, and it should be. And I didn't ask this yet. When you guys are using your glide scope, are you using the rigid stylet or are you using the soft one still?
Rigid.
The rigid one that you're driving from the top. Okay, that's good. I feel like they're so much easier. So it's hard, I think a lot of times we're not, because we're so used to now using the glide scope, doing direct is almost becoming a lost art. Last time I tried direct, it didn't go well because I'm so proficient now with the glide scope. We ended up getting a little glide scope so that when we respond to calls in the hospital, like a cardiac arrest or something in the hospital, or we just need to go intubate in the hospital, we have a little glide scope, probably just like yours with us. So help from your friends, so remember, it's not about ego, it's not the time. Give it up if you need to. And then if all else fails, you can just bag someone. I would definitely want to do that before a crike. All right, so proof of placement. So we know the best way really is to watch the tube go through the cords, but you have a myriad of other ways that you can see if this is in the correct spot. This esophageal detector device, I don't think anyone's seen one in years. Like my first class I taught here, one person knew what that even was and could explain it. Anyway, so you're always welcome to stick around and check out the chest x-ray. I know in the past, you guys had the forms for us to fill out, and it sounds like it's on your computers now for us to be able to confirm that you got the tube, which I love that. A lot of times we can do the same confirmation as you and just say, yep, we're pretty sure just like they are that they got it, unless you stick around for the chest x-ray, which is more definitive for us. So, all right, what's wrong with that picture? So right main stem, good. So this picture really is horrible, and I will say some chest x-rays really are this bad to see the carina. But I think on this picture, I can see this main stem bronchus comes up and the carina looks like it's about right there. And so they're in that right main stem. So typically, when I get a chest x-ray, I want to see the tip of the tube, kind of where the clavicles come together, like over the manubrium. That's about where you want to see it. It depends on how tall the patient is ultimately, but it's going to be a few centimeters above the carina. All right, how about that one? What's wrong with that one? You got arrow sign.
It's pretty crummy x-ray too. Rotated around and everything.
Yeah, it is. I just think, yeah, it's a young person. I think that's what makes it hard too, is that it's just a really young person.
Is it in the esophagus?
It is in the esophagus. So you can see this black stripe right there is the air in the trachea. So this is over here in the esophagus, and you can see they've been insufflating the stomach. So that's a big old air bubble. All right, so this is what I learned in paramedic school. And even still, Except for I held on to it, to the point that my respiratory therapists are like, Dr. Grace, let go of the tube. And I'm like, I can't let go of the tube. I have to hold onto the tube. And anyway, so it's important if you're, sounds like most of the time you're intubating in the back of the ambulance, but if you're intubating on scene, you need to reconfirm after you move the patient to make sure that the tube hasn't moved. So super important to re-auscultate, check for placement after. Okay, which is the first point there. So redosing on the sedative, we've talked a little bit about Versed. Ketamine's good for ongoing sedation. They're both pretty good. One benefit ketamine has over Versed, I would argue, is that ketamine can be used for pain a little bit. Versed is definitely not for pain, but also consider using fentanyl. Just remember that none of the meds that you're giving, like like we talked about earlier, they're paralytic, even though it seems like they're comfortable and fine, is not providing any pain control. So you might see all of a sudden, your intubated patient who's just kind of like rocking life out, their heart rate skyrockets all of a sudden. And you have to ask yourself, has the sedation worn off? Are they feeling pain? So that's probably my first consideration when I see a heart rate go up on an intubated patient, is they're hurting somewhere. So consider those things. And then remember, we're not trying to overshoot our ventilation. Most of the time we're not hyperventilating patients, so you want to keep them between this 35 to 45 value. All right, so lung protection settings. I've been told that you have a chart in your ambulance that helps you with this so that you don't have to calculate ideal body weight. And I love that. You may work with other departments, and we've got other departments online that may not have these charts in the back of the ambulance. This is super important because you think about how obese our population has become, and then you're gonna give someone this huge tidal volume that in all reality has smaller lungs, and you're gonna cause some barotrauma. So make sure you avoid that. Keeping the head of the bed elevated isn't only helpful for the intubation phase, but afterwards too. So helpful for regurgitation, which in theory they shouldn't be having if you've got a good solid tube in. We're preventing that aspiration risk, but even still, we're putting a OG or NG tube in when they get there to further prevent that. So head of bed elevated is helpful there. And then again, back to our obese patients, for a lot of these people, they have a lot of weight on their chest. And so when they're laying flat, all of this weight is just going right up over their airway. So if you can sit them up a little bit, it's gonna offload some of that weight and just give them a little bit better chest excursion with ventilation. And then remember also your history, what caused this patient to go into this airway emergency in the first place. Could it have been that they are a COPDer and they just pooped out and you're tubing them because they just can't keep working that hard to sustain their respiration? Maybe they need some albuterol, maybe they need a duoneb or something. So just remember, you can put that in line with your ET tube. All right, dope. Anybody did you just graduate from paramedic school? Were you here the other day?
Yesterday.
Your mouth is full. Can you teach us dope? I'm tired of talking. You should teach us dope.
D is going to be for displacement.
Okay.
So basically, this is going to be used for, say you're not getting the ventilation you need, right?
Okay.
Intubated patient. So if we look ahead of us here, we have the O for obstruction. So anything like secretions, blood, pus, foreign body.
You're doing a great job.
P, pneumothorax, whether it's a simple retention, and then E is going to be for equipment failure, so, start troubleshooting, right?
Perfect. So, really, if you have this committed to memory, it's not hard. Dope. It's really easy. And in that moment that something goes awry, all of a sudden your patient who was sitting at, 100% on the, vent that you've got them on and your beautifully placed ET tube, you got to ask yourself, what the hell's going on? Do I need to suction the airway? Could they be biting down on the tube? An obstruction can be that. It could be that. Do your tube securing devices have like a built-in bite block? So that's important. They don't all have that, so that's important. So beautifully taught. Thank you. All right. So now we have a secured tube. we're gonna move on to the physiology of the peri-intubation. So, like we talked about earlier, hypotension can be a real problem. I think it scares all of us, trying to sedate someone who is already really hypotensive, and then hypoxemia and acidosis we're gonna hit on too. And this is hop killer, so again, this whole kind of mnemonic or whatever was brought about by Scott Weingart. So if you wanna Google this yourself, you can look at hop killers for more info. All right, so we've all heard of RSI, rapid sequence, but there's resuscitation sequence intubation. So I want you to think about this with hypotension. So this is important because, again, our goal is for the patient to survive. That is that bottom rung of the pyramid, right? This is basic level that we just have to get this patient through this. Some of the things we can troubleshoot them later. We got to keep them alive. So peri-intubation hypotension associated with increased mortality. So for a lot of reasons. So could be that they are a renal failure patient on dialysis. Those people are like always hypotensive. That's something that we're constantly battling. Maybe they have a GI bleed and they just haven't gotten enough fluids yet. So, open those 2 large bore IVs wide up. Could be the effects of our induction agent, our sedation. Could be that our positive pressure, if you're bagging them for some reason already, could be that positive pressure is actually causing some decreased venous return, which is this. So typically, our respirations are driven by a negative pressure system. So as our diaphragm moves down, creates a negative intrathoracic pressure, and then it helps us to draw our breath in. But when we're providing positive pressure, the whole system changes, right? So now we're pushing this air into the lungs, which in turn is pushing on the vena cava. And so ultimately we're getting decreased preload to the heart, which decreases our cardiac output and our blood pressure. So positive pressure ventilation, so once you even put them on your vent or you're bagging them, with the tube in or whatever you're doing, just keep that in mind, that even just the bagging could be the reason why their blood pressure is coming down. And the way that we overcome that is with fluid. So if you put more into the pump, I'm explaining pump hydraulic stuff to you guys, but you guys know this. Anyway, engineers? No, okay. Anyway. All right, so basic strategies, so 2 large bore IVs and IOs are fine. You can dump some fluid into an IO. Shoot for higher than normal blood pressure before intubating if possible. So 140 is a pretty lofty goal, and it's hard because there are times that we're actually practicing permissive hypotension. So if you've got a head bleed, if you've got, you don't want to pop the clot kind of thing going on. So some of these things you have to kind of weigh the pros and cons of maybe some competing ideas. And if you're more of you like to go off maps, the map that is suggested is about 80. If you want to go off of a map rather than a systolic. So one of the interventions that Dr. Weingart suggests for trying to overcome the peri-intubation hypotension is to do low sedation and high paralytics on your dosing. You can't over-paralyze someone, I will just say that. It is hard if you're only giving ketamine. Ketamine, to get to, and that's what everyone's using, it sounds like. So remember, to get to the point that you are hitting a dissociative dose, you can't just be giving a whiff of ketamine. You have to give a decent amount to get to a dissociative dose. So maybe a reason to give etomidate, I don't know, you'd have to decide, I guess, but let's see. Oh yeah, paralytics are going to take a little bit longer to work in a shock state. So one nice thing about ketamine, as far as a plug for ketamine, is that it's what we call a first pass drug. So essentially, with one circulation of ketamine through your system hitting the brain, you're going to get the full effects. And so that's kind of nice. So you can titrate it, but and maybe that would be a reason to do it if you're trying to dump fluid into somebody and you feel like you've got a few minutes, then you could maybe dump some fluid in while you're getting them to that dissociative effect rather than just slamming 1 per kg or whatever. Sometimes he'll even suggest doing 0.5 per kg initially. So here's his suggestion. So giving 0.5 mg per kg and then giving additional doses until they're fully sedated or dissociated. And then giving a higher dose of rock. So if you look up this term, rockettamine, there's some controversial stuff. So like Chief Cook said, there's a lot of information out there on social media. Dr. Weingart hosts a podcast called EM Crit, and a pulmonology friend of his hosts one called Pulm Crit. They're like sister podcasts. His name is Farkas. I've got information on him here in a minute. And he put out a post that kind of talks about this rockettamine and how you should think about rockettamine. There's a little bit of controversy about it, but we're going to hit on it and then make some suggestions. So when you look at ketamine, if you're doing kind of this titration of ketamine, essentially you're kind of on this downward roller coaster looking slide, I guess, if you will, to sedation. So you have this longer sedation lag time, which probably isn't ideal if you're looking at someone who is also hypoxic. So this might work for someone who is more just hypotensive, but not hypoxic because of the sedation lag time and the need to hurry and get an airway. So the ideal thing would be if you can give something and then it just drops them off the cliff as far as their sedation, so that you can hurry and get your paralytic in. So here's what he suggests. So he suggests doing rock and ketamine, but he actually pushes the rocuronium first. And he does this because of the time of onset of each of these meds. So you can see, and again, this is maybe important and helpful when it comes to hypoxia. Your sedation lag time is going to be less. What Dr. Weingart says is you could push them really fast together, or push your ketamine first, but don't wait. Don't wait 30 seconds to push your rock or your paralytic. So it's a little bit controversial. If you want more information on this, so you have to subscribe to both of the podcasts. I don't pay to subscribe to them, but if you want to work around and you want to hear what Scott Weingart talks about as far as the timing of these medicines, you can listen. It's on podchaser.com. It's called Ketamine, then Rocuronium, DSI, and a timing principle. This timing principle has been actually really well studied in the anesthesia literature. And so they say if you give the paralytic first, you're not wrong. But could there potentially be some downfall with some awake paralysis for a short period of time? Anyway, I thought this was interesting just with regard to the sedation lag time. So if you have someone that you really don't want them to be sedated for a while and not breathing and extend your apnea period, then give them really close together, don't wait. So, and sometimes this happens, if you're giving your own medicines, you're in charge of this. I will tell you, I don't give my own medicines, and that is one thing that Scott Weingart advocates for fully, is drop your own meds, give your own meds. And it sounds like you guys are doing that, but when I ask for meds, I'm asking for, okay, well, give me etoposide, and then, I want the rock, and sometimes it's like, oh, it's already been given, or sometimes it's like they miss it and they haven't given it yet. I'm like, what, you didn't give the rock yet? Okay, we'll give the rock now. Why didn't you give that yet? Whatever, so just be clear on your timing. So, anyway. So then there's just some information on which one you give first. So reduced first pass success with paralytic first, risk of anesthetic awareness when giving rock first, and it does happen, so maybe a reason not to do that. Okay, so, and when it comes down to it, I think I would actually do these in reverse order. So the first intervention that was recommended was the low sedation, high paralytics. I'm a big push dose pressor fan. I do this in my ER all the time. So I recommend having this ready to go if you can, and I would do this first line. So again, we're shooting for that higher blood pressure, so a low threshold for giving this. I will tell you a story. This works really well, and it works super, super, super well if you use the 1-to-1 vial, which I asked a nurse to mix up some of this push dose epi for me one time, and she'd never done it before, so she pulled the 1-to-1 vial, and I was like, wow. This guy's blood pressure went from like super crappy to like 220 over like 130. I was like, wow, well, he really, really, really likes epi. And it was because I gave him a really high push dose pressure dose. So anyway, just remember it's cardiac epi. And again, on this, perfect practice makes perfect. So this is a little bit tricky, and that's why I tend to draw this up myself, because usually the nurses look at me like, how am I supposed to get that into here? And because you're drawing out of that preloaded cardiac epi vial, so it is a little bit tricky. So make sure you're practicing this when you're doing trainings and you have access to it, so that you can see how to do it. Or after your call or whatever, when you've got a vial of epi sitting there, you know, you can practice drawing out of that vial. So I had printed an extra one of these. These are stickers that I had made up, or that I made up at home. Just so that you can label your push dose epi, because by the time you have your syringe full of sedation and your syringe full of neuromuscular blocker and you've got flushes all over the place, you're like, oh, which one was the push dose epi? So I feel like that's helpful, and it has the little recipe on there. I never remember how many mics I have per mil, so for me, I actually keep one with me at work, and I try to label it as soon as I'm able to get out, or I hand it to someone who's not involved with the code, and I just say, hold this is push dose epi, don't put it down. So anyway, I know last time you asked, you know, how do I use push dose epi, and I am really pretty liberal with this. So I mean, it says 0.5, I've never pushed 0.5 mils of push dose epi. If I'm gonna give it, I'm giving 2 to 3 mils, and I'm not waiting 5 minutes, because I need it to work now. So usually, I'm an impatient person, I guess, but I'm pushing it every couple minutes, trying to get their pressure up. So I think it's okay to be aggressive with that. And then you guys carry peripheral pressors, which most people don't. And Chief Cook, I'll let you advocate for push dose pressors in the field. To me, or sorry, for peripheral pressors in the field, it seems like a lot of work to me. I'm such a fan of the push dose that I would defer to that every time, but I know Chief Cook is an advocate for
Well,
this.
and I'm gonna reflect what Dr. O has shared with us, which is, the literature really says that the push dose, as it was originally designed and intended, was meant to be a bridge to long-term ongoing pressors on your pump. So is it a pain to mix up and to draw up? And yeah, it's, if you don't do it in practice, if you don't do it and it's foreign to you, it's gonna take a while. But just like Dr. Grace the other day, she said, you should practice this with your cardiac epi and how to draw it up. We've got vials of that stuff right back here. There's no reason not to practice it. But what I said is, while you're having that conversation, you should also practice mixing up a ongoing pressor and pull the pump out and know where to get to your vasopressin on there, or whatever, right? Your epi, if that's the one you choose, so that you can put that on and use it as an ongoing medicine. And so that's Dr. O's hope. Is it gonna happen every time? No, I understand that. But you may have occasions beyond just when you're using it on interfacility transfers, that if they're receptive to your push dose and you have the time, get them on the pump and get them on a pressor. That's from Dr. O. Understanding you're not gonna do all the time, but, and if all you end up doing is push dose, that's fine. But we can elevate our game as we get more experience and more providers, and as we practice more, we can elevate our game and elevate our care. That's all he's after, so.
I think as I was putting this slide in here, I was contemplating, like, what is the farthest reach of your response zone? Like, where's your farthest response, like, where you're responding and then taking the longest to get to the hospital? Where would that be for you guys, just out of curiosity?
Either way up east or way down south and
Or
west,
a mutual aid call.
or a mutual aid call.
Sure,
So,
okay. And it does offload the task of having to constantly give push dose epi, and if you really need it, I mean, there have been times where, like, I blew through a whole vial of push dose epi, and then I was mixing it up again. So again, that's also cumbersome. If you're going through a whole vial, you've gotta mix it up twice, which probably would take the same amount of time to just mix this up once. So just remember, you really do need to have good access. I haven't seen your protocol, and what are you carrying? You said Epi and Levo,
Levofed.
and you said vasopressin. You're not carrying. Okay, okay, okay.
So I
Um,
cross over to the other place too.
That's okay.
So.
So just remember, you need to have a good access point. It really needs to be like an EJ or an anacubital access. I have seen people lose. I had a lady when I was in training who lost her thumb because that was the only access they could get, was a little tiny thumb IV. And I mean, Levofed does what it's supposed to. It vasoconstricts to the point that her finger didn't get any good blood flow. And also if it infiltrates, then it's really necrotic for the tissues. And so just keep in mind that you want to have good access. And ultimately, you know, someone's going to have to put in a central line once that's placed, but you can do peripheral dose pressors through just a regular peripheral line for about 4 hours as long as it's a good line. Okay, and awake intubation, no one's doing that in the field. I mean, I don't, we're not talking about that. Okay, so hypoxemia. So this is refractory to normal pre-oxygenation, which we're gonna talk about maybe some paradigm shift for what normal means. So normal, this is what is recommended from Scott Weingart. So we talked about the 15 liters nasal cannula, and 15 liters, just crank it. Some of your regulators will go up above 15 liters. We're really just cranking it. These people are sedated and paralyzed at this point. They're not feeling you blast their nostrils off their face, so just turn it up. And then pre-oxygenation also with high flow oxygen through just a non-rebreather mask. So we're gonna wanna do this for about 3 to 5 minutes. So picture like the picture earlier. We've got a non-rebreather with a cannula under it. They're both maxed at 15 or as high as you can go, okay? This is what we're doing for pre-oxygenation. So we're not bagging at this point. We're trying hard not to provide any extra positive pressure because we're, again, avoiding the risk of aspiration. So this Taha et al. Showed that apneic oxygenation with a nasal cannula during RSI in comparison to those done without it showed DSAT of 6 minutes compared to 3.65 minutes. So that's a substantial amount of time that it buys you on your apneic pre-oxygenation. So I like that number. Okay, so again, we're doing nasal cannula, 15, non-rebreather at 15. And then if you can't get a SAT above 95% with that, because that's a lot of oxygen, if you still can't get a SAT above 95%, Dr. Weingart says you need to think about shunt physiology. So this could be pulmonary edema, but these people need PEEP. So a shunt essentially means you have good blood flow, your blood flow's fine, you're bringing in good blood that should be in theory getting oxygenated, so why can't you get your SATs up? Well, because there's some sort of a problem with the alveoli directly. So it could be that they've got atelectasis. There are a lot of people that have that for whatever reason. It could be compressive from a trauma. They can't expand their lungs. It could be because they've got pneumonia or they've got pulmonary edema with some fluid in there that's obstructing that gas exchange. There's some sort of a defect there. So if you can't get their SAT above 95%, you've got to think about this. The way that he says to overcome it is, again, nasal cannula, 15, but now we're putting on a BVM at 15 liters per minute with, and it's no different from your non-rebreather if you're not doing this, with PEEP. So between 5 to 15. So easy to remember, 15 liters nasal cannula, 15 liters on this by BVM with up to 15 liters of PEEP, okay? Or sorry, not liters, 15 centimeters of water. So I would probably start at 10, but if you're still not getting, you know, the SATs that you want, then you can turn it up to 15. Or if you just remember 15, 15, 15, that is also fine. So again, we're not bagging these people, but if you have a good seal, you're providing PEEP. So you don't need to bag these people. So Dr. Weingart talks about this will sustain and keep those alveoli open because of that little bit of positive pressure just from holding the seal. Every time you bag, it's popping the alveoli open, but then they're closing again each time you're not bagging, if you're not keeping a good seal and that sort of thing. So if you're doing this right, you should be providing some good PEEP. But that also means that you could see the effects, because this was a kind of an argument that they were having on his podcast about, well, are you gonna see the effects of this positive pressure and decreased venous return and hypotension from just this? And you can. He argues that when you're doing this without even bagging, the positive pressure that you're providing with just this setup and a good mask seal is enough that it could cause some hypotension. So just keep that in mind. But right now, we're kind of talking about overcoming the oxygenation issue. And kind of talk about those three things that we're highlighting here with hypotension, hypoxemia, and acidosis. He talks about how if you have one of these, you're in trouble. If you have two of them, you're in a really, really bad way. So if you can overcome at least even one of these, I mean, obviously we're gonna try to target as many of these things and optimize the situation the best we can, but if you have to pick and choose, pick one and see if you can get through that. Okay, any questions on any of this? I know this is a lot. No? Okay. So we talked about resuscitation sequence intubation for the hypotensive patient. So now we're going to talk about delayed sequence intubation for someone who's hypoxemic. So if you think about this, and we think about this in the ER all the time, we're procedurally sedating people to put their arms back together after they're fractured. We're doing procedure sedations, and you guys do too, I guess, when we think about like if you're doing defibrillation, like a synchronized defib or something, you're sedating people first. So it's the same kind of thing. So we're sedating someone for the procedure of pre-oxygenation. So if you think about a combative head injury patient who has a poor respiratory status, you've got your BiPAP on them and you're trying to get their SATs up and they're like ripping it off because they are confused from their head injury, or a stroke patient, or someone who's high on pick your poison. So we're sedating them with ketamine, but we're waiting to give our paralytic, and we're pre-oxygenating for a longer period of time until we can achieve improved oxygenation. So procedural sedation for the procedure of pre-oxygenation. So this is his bread and butter, Dr. Weingart. This is his premier, if he had to say, this is what I've done in my career, this is what he has done, is this delayed sequence intubation. So there's no reason we need to be forcing intubation on somebody who is hypoxemic unless there are other competing concerns. And we should be able to sedate them and get their SATs up. So agitated combative patients, if RSI is going to be challenging. So obviously we're not doing this in an unconscious or apneic patient. We all learn that when it comes to BiPAP, we shouldn't be putting BiPAP on people who are really altered because of the risk of aspiration. And that's totally true if you're going to walk away from that patient. If you really can't watch them to make sure that they're maintaining their airway, then yeah, you shouldn't put them on BiPAP. But if you're going to sit right next to them, he also argues it's okay to put someone on BiPAP even if they're altered, as long as you're watching them and you're kind of watching for signs of possible aspiration. But if they're apneic, you can't do this because they have to be able to breathe. That's the whole point. We're giving them ketamine, and only thing that works, you can't give them etomidate and do this, right? Because etomidate is going to make their breathing stop. But with ketamine, you can, because they're going to be sedated, but they're going to be breathing. Questions, comments, concerns? Okay, so just to compare rapid sequence intubation with delayed sequence. So rapid sequence, we're giving these meds super fast together like we talked about. We're doing this in patients who are totally unconscious, maybe not breathing, at risk for aspiration, and we're doing etomidate and ketamine. Either are fine. With a neuromuscular blocker. And then on delayed, we're doing this because of hypoxemia. We can't get their oxygen sat up with the traditional ways that we're trying. And then we're only providing the sedation first while we're pre-oxygenating. This is for the combative, agitated patient who doesn't otherwise tolerate the pre-oxygenation. And we're only using ketamine. Then we're pre-oxygenating, then we're giving our paralytic. So this is the third intervention if you're dealing with someone who is hypoxemic despite all of your attempts at pre-oxygenation. And I mean, this one, I think this just goes without saying. We should be doing this pretty much every time. It shouldn't, I don't think, be intervention 3. We just need to be doing this. So this is what this looks at. Back up, head elevated. I don't like the BUHE acronym. I like this HELP, head elevated laryngoscopy position if you're like an acronym person. But we've already talked about all of the benefits of having someone's head up. This says 30 degrees, and that's what's always recommended. This picture is not 30 degrees. I'm married to a carpenter, and he would be like, no, that's like at least 45 degrees. So, improves the view, could prolong your safe apnea time, and again, just makes lung excursion a lot easier too. Okay, our last thing, which is really fast, metabolic acidosis. So how can you tell in the field if someone is acidotic? Because I have the advantage of, doing a blood gas, seeing what their lactic acid is. How do you guys tell? So end tidal, so that's good. What kind of historical or physical exam findings would you maybe see that could cue? So diabetes, right? So you could use your glucometer to know that their sugar is greater than 500. What about your nose with diabetes? Who can smell ketones? Anybody? I can too. Like, it's like a curse sometimes because they're so strong. But I can walk in and tell you if their sugar is 400, if they're in DKA or not, because I can smell it. So if you don't know if you can smell ketones, find someone that can. I do this to med students that I have sometimes. I'll be like, I want you to go put your face right in front of their face and smell their breath. And they're like, what the hell? And I'm like, I just need to know if you can smell ketones, So find someone that knows and find out if you can. So looking for some of these signs, so maybe Kussmaul respirations, changes in LOC. I mean, if someone's been down for a really long period of time, they're going to be acidotic for sure. Vomiting and diarrhea. Yesterday I mentioned with our normal saline, the chloride in it, if we're giving a lot of normal saline, we can actually induce some acidosis. You're probably not going to see that a whole lot, but and we like to give NS in those nausea, vomiting, diarrhea patients because we need them to have some sodium back in. But usually after we give a couple liters of NS, we're going to switch to LR so we don't induce more acidosis. So bicarb, don't do this. It's actually deleterious. It can actually push people into more acidosis, which is kind of paradoxic, but it is the case. So there's no evidence to show giving bicarb will help. Obviously, we're giving that in the arrest situation. We're hoping it's going to make our epi work better because we know epi doesn't work super great in an acidotic environment, although you have to get to a pH of like 6.8 before epi stops working well. But I have definitely, and probably you have too, seen where we give bicarb and then all of a sudden, we get a rhythm back with epi, but it wasn't until we gave the bicarb. So keep giving bicarb in the arrest setting, but not in DKA or for some other reason. And then this we're not really going to hit on at all. This is, he suggests hooking up your ventilator for pre-oxygenation. This is a lot of work. Ultimately you are going to be hooking up your ventilator already, but the settings and stuff get a little bit tricky. So we're not going over that. All right, so summary. I know this was a lot. So do you need to intubate? Have you exhausted all other options? Taking the airway is a big deal. Are they in cardiac arrest? So do you want to wait for a little bit, maybe until you get ROSC if it's looking futile from the beginning? Probably your airway is not going to save them. They've been down for a long time. Can you do it without meds? Rapid sequence, we talked about if you have some sort of a situation where you just need to get in there fast and get it done. Risk of aspiration. For hypotensive patients, we're thinking about resuscitation sequence. Again, I argue pressors first, low sedation, high paralytics, giving them pretty close together. And then if they're hypoxemic, we're going to think about, there we go, delayed sequence intubation. And remember, 15 on the nasal cannula. For normal oxygenation, we're doing 15 on the non-rebreather. And then if they're still having refractory, like under 95% oxygenation, then you're going to put them on the bag valve with up to 15 of PEEP. So sedate to oxygenate in that combative patient, and just put the head up. All right, so tube these, it says, you probably can't read that from the back, it says, because despite amazing advances in science, your patient cannot yet breathe through his stomach. So maybe we're headed there, we've come a really long way, so who knows, but questions, thoughts? I know that was a lot, it was long. Thank you for bearing with me. Okay.
Dr. Grace, thank you so much.
Yep.
Thank you so much.
To disconnect my.